Well, thanks a lot, Arthi, for inviting me to just give a little mini talk. This is just a short 10-slide mini lecture on MRI contrast agents. It's sort of based on a little mini talk that I often give for our residents and also our technologists on just a few principles about relaxivity and different contrast agents and a couple other little fun and hopefully useful things. So what I'm going to talk about just is some basic principles of relaxometry. I'm not going to get into the hardcore physics, just a little bit of the equations and where relaxivity comes into play. Talk a little bit about contrast agent properties, but also spend more time on how to actually calculate the contrast dose, because some of you actually may not be familiar with. And it's important to understand the differences in the formulations between the different contrast agents in order to do that. So what is relaxivity? It's essentially it's part of this equation here, where we're looking at the change in R1. So big R1 is just 1 over T1, and it's proportional to the contrast agent concentration. So that's the number of, say, gadolinium molecules that you have in the tissue, and that linear relationship is the relaxivity, or the bang for your buck. So it's the amount of T1 shortening that you get per molecule of contrast. So when it's a nice way of comparing the performance of different contrast agents. So again, for a given concentration, that's how much signal brightening you're going to get. Important to point out too is that it can be gadolinium, but other things can also serve as contrast agents: manganese, iron-based contrast agents. And in the old days, we even talked about dysprosium and europium and things like that. It's usually gadolinium, though. The other thing I want to mention is that it's not just for T1. You also can talk about T2 relaxivity, and you can even talk about T2 star relaxivity. So this is the amount of shortening that you get in the T2 in a spin echo weighted image. So for example, the middle equation, or for gradient echo acquisitions, you can talk about the little R2 star relaxivity. And so it's the same formulation. The higher the concentration of the contrast agent, the more shortening of the T2 or T2 star that you're going to get. And so contrast leads to shortening of, or at least a darkening of T2 weighted and T2 star weighted images, and it leads to brightening of T1 weighted images for all the reasons that you know. And so just a reminder that relaxivity just isn't for T1 anymore. And if for those neuroradiologists out there, if you are doing dynamic susceptibility contrast enhanced imaging, for example, it's really this bottom equation here, where you're doing a T2 star weighted image very rapidly. Now this slide is super busy, and I'm not going to go through every box, but I will make the point that this is basically everything you need to know about contrast in one condensed manner. And if you guys are interested in this, it's actually posted on the University of Wisconsin website. I'm also happy to send you a copy of it as well. And I just want to kind of go through this to give you sort of some general themes. So I've listed the generic name on the left next to the brand name. And I do want to make a point that I think it's really important in your practice to be using the generic name when you're talking about a contrast agent. It's kind of like saying, if you use the brand name, it's kind of like saying, Advil or Motrin, when you really should be talking about ibuprofen. So you don't need to know all of the names, but what you should figure out are what contrast agents are at your institution, and then you should know the specific generic name. I also have the manufacturers listed here. Not that important, although you will see a few themes. For example, Bayer has Magna Vist, and Bayer has Gada Vist, whereas Bracco has Multi-Hance and Pro-Hance. And actually, GE has a new contrast agent, which is a generic of gadodorate meglamine. It's the same as Dodoran. It's called Clariscan. So you can kind of tell a little bit about who makes it as well. Not that important. I've also shown ferromoxetol at the bottom here, which is not a gadolinium-based contrast agent, but I listed here because we do use it as an MRI contrast agent. So a few general properties to think about are pharmacokinetics, and that's listed over in this column here. Extracellular fluid agents, hepatobiliary, intravascular, or reticuloendothelial. The majority of agents have extracellular behavior. Multihance or gadobenate dimethylamine is about 95% extracellular with a little bit of hepatobiliary, whereas gadoxetic acid or Eovist is about half and half. There are some other features here as well, including protein binding. There's some protein binding for gadoxetic acid and some weak protein association of gadobenate dimethylamine as well. Another feature that is really important, especially when you're calculating the dose, is going to be the formulation. Essentially means the concentration. Most of the original agents were all half molar formulation. Gadovist came along and was actually a high concentration agent. It's a full molar. Multihance is also half molar, whereas Eovist is a quarter molar. And that's going to be important when you want to know how many milliliters do I need to inject into this patient. I should put safety in quotes here a little bit. Some people like to break down between macrocyclic and linear. I think that this gets into some of these gadolinium deposition issues, which I'm certainly happy to talk about. NSF safety certainly does matter as well, and that's really captured over here in the NSF safety group. You'll note that there are only a couple of agents. In fact, I think Magnavist has been taken off the market, so there's really only one group 1 agent. Those are the agents that are associated with NSF in patients with renal failure. Group 2 agents are those that are are generally considered safer. And if you had to give a gadolinium agent in a patient with renal failure, you would probably want to give a group 2 agent. And I'll note that there are 3 macrocyclics and 1 linear agent. So from an NSF point of view, it's incorrect to say that macrocyclic agents are safer because some of the linear agents are also considered safe. Gadoxetic acid is a group 3 agent, which means that it is not associated with NSF, but it is has a shorter track record on the market. And it really came out in the United States in 2008, right after NSF had broke. So there probably is not sufficient exposure to really be confident, at least not at this stage. And then the other thing I want to point out is this big field here in the middle, which is the relaxivity. Some people talk about standard relaxivity and high relaxivity. I think that's a bit of a judgment call, but really the point here is that you can find the little r1 over here. Note that it changes with field strength. It actually goes down in general at higher field strength. And the other thing I want to point out is that some of these agents have relaxivities that depend on the environment. So whether it's in saline or plasma or blood can make a big difference in the relaxivity of the agent. To calculate the dose,
I have a couple of questions about that last one.
You bet.
So one is the protein binding. What is the importance of that?
Yeah, right. So the protein binding is important for a couple of reasons. The main reason it's important is that it slows the tumbling of the molecule. The larger the gadolinium or contrast agent molecule is, the easier it is for a water molecule to come in and exchange energy with it. And so that will increase the R1 relaxivity. So if it's a little sticky, let's say to an albumin, for example, it effectively slows the tumbling rate and it increases the apparent relaxivity. So for example, I believe, and I'd have to double check this, but I think that the 6.3 with Multihance is in saline, whereas the 8.1 is in human plasma. And so that's probably because there's albumin that's present.
Okay, so those agents will appear more robust in their signal intensity because of their protein binding.
They will give you more T1 shortening and therefore they will be brighter. And here's a little interesting thing to think about it. When it's in the vial and you're injecting it, it's not associated with any protein, right? And then it takes a little time for it to mix. So some people will even talk about the idea of transient relaxivity, that the relaxivity actually has to come up to speed. You'll notice that one of the agents that's missing here is gadophosphate, trisodium, which was known in Europe as Vasovist, and in the United States it was known as Ablavar. I took it off the list here because it's no longer available. It had a very high T1 relaxivity, and the reason is that it had binding with albumin.
Cool. Okay, and then for this NSF safety group, you're basically saying the group 2 agents are safe.
There is a black box warning on all of the agents. The ACR safety committee says that if you had to give gadolinium in a patient or if you wanted to give gadolinium in a patient with renal failure because there was a compelling clinical need, that you should feel better about going with a group 2 agent than a group 1 agent, for example. They also say that it's now considered optional to screen for renal failure in patients with patients in agents that are group 2.
Okay, thank you.
All right, keep going, and just a couple more slides. So how to calculate the contrast volume, pretty simple. What you really need to know is how many milliliters for this patient to inject. And so the first thing you want to know is the patient's weight. So if you're doing a weight-based dose, then it's going to be proportional to the patient's weight in kilograms. If it's higher concentration, you're going to need less. So the higher the concentration, the lower the volume. So that's why the concentration goes in the denominator. And then the dose is typically given in millimoles per kilogram. There's no reason you couldn't give this in milligrams per kilogram, so long as you knew that the concentration was also in milligrams per milliliter. But the standard approach for gadolinium is millimoles per kilogram, and then that gives you the volume in milliliters. This is actually a little tool that folks might be interested in checking out. We found that our technologists were not on the fly. It was challenging them from a workflow point of view to actually do this calculation. And when we started imaging with gadolinium acid, which had this 1/4 molar, it created a lot of confusion about what the right dose was. So we actually made this online gadolinium calculator, which you can check it out. It's on the internet. And I'll show you, I'll give you a little demo of that. In fact, we actually had so much traction from this that we actually made an app for it as well. So if you go to, for iPhone and both Droid as well, if you search on gadolinium calculator, you can download this. It's free, and it's not that exciting. It does have the package inserts there available as well. Their package inserts are also available on the website. So let me give you a little demo of how this works. So here's the link, and let's see if I click on this, see if this works. Yep, I'll pull it over here. Can you see are you seeing the calculator?
Yes.
Perfect. Okay, so there's a little disclaimer, and by the way, there's a link to the App Store as well to download the calculator. And then just pick whatever your favorite agent is. It doesn't really matter. Let's just take the top one here. And then we have it fill in a standard dose that we like to use at Wisconsin, but it might be different for certain applications. So for example, a cardiac MRI, we use 0.15 millimolars per kilogram. And then you just enter the weight, let's say 100 kilograms, and hit return, and it gives you the volume that you need. If you enter some ridiculous weight in that's like not feasible, like 500 kilograms, well, it's supposed to give, yeah, it gives you, well, it usually gives us a warning. Well, anyhow, it didn't give the warning. On the app, it will give a warning to say that that's just not feasible. So anyhow, and then you can change the agent if you wanted to. So for example, if you went to Eovist, which is a 1/4 molar, and it filled in the dose for you, and let's put in a smaller weight, you can see 5 milliliters there. Okay, so that's it. A few takeaway points. Not all contrast agents are equal, both in their pharmacokinetics, their formulation, their relaxivity, and there's a lot, and also some safety considerations. So there's a lot of factors that go into choosing an agent. Cost is another one, of course. It's really important for you as radiologists to know how to calculate the dose, especially if a question arises or if you have some tricky case like a tiny little baby and you really aren't sure exactly what the appropriate dose is. And we have this gadolinium calculator, which we call GadCalc, which is a useful tool. If you guys have any questions at all, certainly feel free to email me and I'd be happy to talk about those. All right.
That was great. Does anybody have any questions? You can either chat them in or speak up. I have a couple more questions. What are your thoughts about the brain deposition?
Oh, yeah. Well, I think that there are a lot of unknowns, and there's a lot of emotion, and there are a lot of opinions, and I think that we need more data. And I think that there are a lot of people out there trying to make full professor on trying to expound upon their opinions. So I think a lot of it you have to take with a grain of salt. I think that the concerns are certainly very valid in the sense that gadolinium is not an endogenous element within the body, and if it's in what should be a sensitive place like the brain, that would always raise concern. That being said, it is a place where other metals are known to accumulate, and to the best of my knowledge, there are no known adverse effects at this time for gadolinium deposition. It doesn't mean that we won't find any. I do think that the deposition phenomena, which is what I like to call it in the brain, is largely an effect that we have this really amazing assay to detect the presence. It's called T1 weighted MRI. And I can imagine that if you had a great assay for iodine, for example, that after getting CT scans, you'd probably find iodine there as well, but we just can't see it as well with CT. I do think that the NSF thing is certainly real. This gadolinium deposition disease that people talk about, I think, is a different entity than the deposition phenomena in the brain. I think there's a lot of anecdotes, and it's very difficult to know exactly what that means. But at this time, there really aren't much in the way of data on establishing a causal link between gadolinium deposition and these symptoms that people are reporting, which I'm sure are very real. That's my opinion.
And we have another question from one of our participants is what are tips to reduce transient severe motion artifact on arterial phase with Eovist? And does dilution help, or does slower injection rate help?
Oh, that's a great question. I don't know, and I think those are very real possibilities. We actually did a study a few years ago with a few friends where we did a multi-center study where we did a randomized blinded placebo-controlled trial to look at this. And sure enough, the effect is real. There was a definite decrease in the length of time that people could hold their breath in our group of healthy volunteers by about an average of about 10 seconds shorter than normal. So I do believe that the effect is real. There is some heterogeneity in the retrospective reports as to whether the effect is present or not. It seems that the effect is related to the length of the scan time. So what we found in our data is that before or when we injected with saline or another gadolinium agent that wasn't gadoxetic acid, that everybody could hold their breath for more than 20 seconds. With gadoxetic acid, there were a few people that could not hold their breath for more than 20 seconds. And our typical breath hold for our scan times, for example, is on the order of 20 seconds. So you could imagine respiratory artifacts in those patients. So one immediate solution is to shorten your scan time. And injecting it more slowly or diluting it, I don't know, but that would be a great study to do. And it's very feasible or plausible that that might happen, but I don't think we know.
Okay. Thank you. Awesome.